Hello, and welcome to the Well Baby Nursery. I'm Dr. Mary Cohn from the University of Colorado Hospital. If you've been taking this course from the beginning, you now have a great deal of information regarding the assessment and care of newborns. In this module, you'll finally get a chance to see a real baby. I will examine a 3-day-old boy named Austin. I hope to touch on some of the topics we have already covered in order to make them seem more real to you. Before beginning the newborn exam, there are a few things that you need to do. The first is to check vital signs, particularly heart rate and respiratory rate. The normal heart rate for an adult is 60 to 100 beats per minute. The normal heart rate for a newborn is much faster, with a range of 100 to 160 beats per minute. When listening, you may hear some variation. The heart rate in all people speeds up when breathing in and slows down when breathing out. This is not very dramatic. When a baby is in deep sleep, their heart rate can drop as low as 80 to 100 beats per minute. We become concerned if it's lower than 80 beats per minute. This should be investigated. In fact, the American Academy of Pediatrics, in its neonatal resuscitation program, states that a heart rate beating at less than 60 beats per minute is not effective and requires intervention. The respiratory rate refers to the number of breaths baby takes in a minute. Babies in the first several days of life have a unique breathing pattern known as periodic breathing. This is the result of the immaturity of the respiratory center of their brains. Periodic breathing means that the baby will breathe rapidly for several breaths, slow down for several, and then pause briefly before starting again. The pause can be up to 15 seconds long. You can imagine that this can be frightening to new parents. Be sure to count the breaths for a full minute. You can do so by listening with your stethoscope over the right side of the chest, or by carefully watching as the chest rises and falls. In this way, you can appreciate the periodic breathing pattern and get an accurate respiratory rate. Temperature taking will be demonstrated in an upcoming module. In the immediate newborn period, we worry about low temperature as well as high temperatures. After the first 3 days, we become more concerned with elevated temperatures or fever. Normal temperature range for a newborn in the first 3 days of life is 36.5 to 37.5 degrees Celsius or 97.7 to 99.5 degrees Fahrenheit. After the first 3 days of life, fever is defined as 38 degrees Celsius or 100.4 degrees Fahrenheit or greater. Blood pressure is not usually checked in newborns because it's technically difficult to do. Instead, we check capillary refill. We use a finger to press on the skin over the baby's sternum or breastbone until it turns white, and then release and count the time needed for the area to turn pink again. Normally, it will take 2 seconds or less for this to happen. Next step is a general assessment of the baby. This includes weighing and measuring length and head circumference. We're checking to be sure that the baby's size is within normal range and in good proportion. These techniques will be demonstrated in Course 4. Looking at Austin's general appearance, it is clear that he is a full-term baby. There are a few features that indicate this. First, he's a good size. Second, his arms and legs are flexed while he is resting. We say that he has good muscle tone, that he's not floppy like a rag doll. This is a sign of maturity of his nervous system. When I look at the skin of Austin's abdomen, I can barely see the blood vessels beneath. A premature baby has much thinner skin, and the blood vessels are very easy to see. Now, at 3 days of age, most newborns will have at least some jaundice. This does not mean that they are at risk or need treatment. In Austin's case, you can see that his face is yellow, as are his chest to mid-abdomen. We would want to check a bilirubin level, but it's likely to be in the expected range. Austin's lips and the inside of his mouth are nice and pink. There's no evidence of cyanosis. You remember that cyanosis can be a sign of low oxygen. Often on a physical exam on a newborn on the first day of life, there may be blueness around the lips or of the fingers and toes. That is nothing to worry about. When the baby is born, they're not pink all over. In fact, they're usually blue or white. Over the first few minutes, they begin to turn pink, starting at their lips and the center of their chest. The fingers, toes, and the area around the mouth have to wait their turn as the heart, brain, and lungs get the first priority. By 24 hours of age, we expect even the fingers and toes to be pink. Continue with our general assessment, we look for signs of respiratory distress. Respiratory distress is the most common problem after delivery. It can be a sign of normal transition or an indication of illness. The most sensitive indicator of lung problems is tachypnea, which means a rapid respiratory rate. Remember that the normal respiratory rate is 30 to 60 breaths per minute. If a baby has just been crying, it will be higher, so please check when they are resting. It is easy to see the breathing motions of Austin's chest, and you can easily count his respiratory rate. We're also looking for retractions. You may see the skin below or between the ribs be sucked in with each breath. Austin has very mild subcostal retractions. You can see the skin below his ribs move inward with each breath. He does not have intercostal retractions. The skin between his ribs is not being pulled in. To summarize our general assessment, Austin is a well-appearing, term male infant who has good muscle tone, mild jaundice, and no respiratory distress.